So, good afternoon, everyone. Greetings, good morning, good afternoon, good evening from wherever you're joining us. This is the first Africa Cancer Research and Control Echo for the year 2022-2023, and we're delighted to welcome you. Today, we're going to be having two very notable speakers with us who are going to take us through the first session on the role of HPV testing in fast-tracking cervical cancer prevention in Africa. I am going to be your moderator for the day today. My name is Benda Kithaka. I'm from Kenya, and I work with Kilele Health Association. About the Africa Echo, it's a community of practice where we learn together, we network together as we discuss implementation evidence-based initiatives and interventions to advance cancer control in the African region, including barriers, addressing barriers, having facilitators and additional research that is needed to further advance the adoption and uptake of relevant, locally relevant interventions at the local, national, and regional level. We do hold this every once a month, and today's session is going to be 1.5 hours long. We will have our discussion led by our two discussants, and then we will have a continuous question and answer session where we can respond to all the questions that you may have. A gentle reminder, kindly, if you're not speaking, mute your microphone so that we can have only the speaker speaking. If your bandwidth allows, we love photos and we love to see the faces of the people you're engaging with. Turn off on your video. It also helps us make the session a little bit more interactive. At the same time, I would ask if you have any questions, burning points that you'd like to make, kindly use the chat. We will be monitoring that so that we can be able to pick all the comments that come through. This session is recorded, and because of that, you'll be able to share with you and any other persons who are interested in the talk but could not join us. What we are hoping today is to discuss progress in the uptake of HPV testing, strategies that we can use for scale up across various countries, and we'll also see opportunities that we can leverage that are existing in the existing infrastructure, including that which was created by the COVID pandemic, as we listen to some of the challenges in HPV testing at country level, as well as learn from various implementation that has been done that we could learn from. It gives me delight to welcome our two speakers today. The first presenter is Professor Isaac Adewele. He will be taking us through the didactic session. Professor Adewele is a gynecologic oncologist and global health policy leader. He's the immediate past Minister of Health in Nigeria, co-founder and co-chair of the African Cancer Coalition, and a past president of the African Organization of Research and Training in Cancer, that's the AOTIC. He's also a member of the International Task Force on Elimination of Cervical Cancer in the Commonwealth, and is currently a member of the Lancet Commission on Cancer and Health System Strengthening. Professor Adewele, kindly, you may project your slides and take us through your didactic presentation. Karibuni. Thank you.
Thank you so much. I want to appreciate the organizers of the meeting for inviting me to be part of this initiative. This is the first time that I'll really be participating in your program. And I want to thank Mishka and all the others who invited me. It's quite a great honor for me to speak to you about the role of HPV DNA in fast-tracking cervical cancer elimination in Africa. And I say, good afternoon. I'm in Nigeria, so it's afternoon. Good morning, good evening, or good night, wherever you are in the world. I bring greetings from my hospital, which incidentally was commissioned by Queen Elizabeth II in 1956. That's the hospital to the left and my university to the right. Cervical cancer remains a public health challenge in low body with the highest burden in low and middle income countries. And generally, what is special about cervical cancer is that it is largely preventable. And even when we treat them early, we can still cure them. It is estimated that about 600,000 cases are diagnosed per year, and we lose a woman every 2 minutes to cervical cancer. In 2020, it was estimated that we lost 340,000 women to cervical cancer. In the developed parts of the world, cervical cancer is low down on ranking, but in our part of the world, it's high up. And it is estimated that if we do nothing, we might actually climb over 1 million cases per year by 2050. What is interesting is that over the last couple of years, our understanding of the biological mechanism for the development of cervical cancer has increased due to our understanding of the pathogenesis of this challenge. What is also important is that the discoverer actually won a Nobel Prize a few years back. So to me, the discovery of the association between HPV and cervical cancer is an important one for us. And when the virus lands, I'll go back, that's the virus there, landing on the cervical canal. This is a training slide from GSK. And when it lands, it infects the basal epithelium. And over time, there is gradual infection high up until you have infection of the entire epithelium and shedding of virus-laden epithelial cells. This, to me, is an important mechanism for understanding of the pathogenesis of cervical cancer. And it actually changes the dynamics in terms of what we teach. Initially, we kept on talking about multiple sexual partners, age at early age of sexual debut, and so on and so forth. These, to me, are actually proxy indicators for acquisition of cervical cancer. And HPV infection is the commonest sexually transmitted infection globally. And that's why we say that cervical cancer is a rare complication of a common sexually transmitted infection, because majority of those who develop this infection will clear them. And it is what is also unique about it is that the progression can take up to 20 years from the time of infection to the time it becomes invasive carcinoma. What is also important for us to appreciate is that quite a large number of them, either with the infection or with CIN1, 2, or 3, will regress. And so the closer the lesion is to normal, the higher the chances that the lesion will regress. This is the time-honored WHO global strategy for cervical cancer elimination. And here we're talking about primary prevention, secondary prevention, and tertiary prevention. For the purpose of this discussion today, we are interested in secondary prevention, and that is the elimination of pre-malignant lesions before they become entrenched as malignant lesions. So you are talking about ensuring that we break what we call the translation of CIN3 to either microinvasive cancer or frankly invasive cancer. The global elimination strategy of the WHO with 2030 target seeks to ensure that we vaccinate 90% of girls by between age 9 and 14 before they attain age of 15. And that we also screen using a high performance test 70% of women and treat 70% of those with pre-malignant lesions and offer treatment with 70% of those who have invasive disease. And then ensuring that 90% of women with cervical disease, they're actually treated. This map of Africa shows us the paucity of screening program across Africa. And apart from South Africa, and that is That's Botswana. The two greens there, South Africa down there, Botswana there. Those are the two countries that can boast of a good screening program. Although even in South Africa, those who work there will tell you that they are yet to have a fully nationwide screening program. But the majority of other African countries are poorly covered with respect to cervical cancer screening programs. Why incorporate HPV testing in cervical cancer screening program? What is important is that scientific evidence shows clearly that it is possible to reduce cervical cancer mortality through screening with cytology, the time-honored pap smear, HPV testing, or visual inspection with acetic acid or iodine that we call VLI. And this has been demonstrated clearly at the British Columbia district of Canada, where the deployment of cytology across the population demonstrated clearly that we could actually eliminate cervical cancer within the community. There's also evidence that shows that HPV testing is more accurate and effective in identifying women at greater risk of developing precancerous cervical lesions, and that screening intervals can be longer with these tests. The importance of HPV is that HPV testing has superior specificity. The strong negative predictive value is important so that when an individual tests negative to HPV, we can safely go to bed and sleep. And this is not what you have with the cytology. Even when you are negative with the pap smear, you still have to keep on testing in order to ensure that you do not miss cancer. And what is also important is that the test sample can be taken by a healthcare provider, or the woman herself can do it, which we call the Sept test, self-sampling technique. And this, to me, has actually improved acceptability and access to services globally. And also, existing technological platforms like the GeneXpert platform, which we use for HIV, for TB, can be deployed for HPV testing, which to me is quite important, and it could help to optimize the workload that we gradually undertake in the laboratory services. It is also important to highlight that HPV testing is more cost-effective than VIA and pap smear. The problem with pap smear is that we cannot afford to implement a pap smear program in Africa because of the demand in terms of services, pathologists, cytoscreeners, and also the need to come back on and on and on again. The loss to follow-up is huge, especially when the patient has to come back in 2 or 3 weeks' time and we'll say, oh, sorry, the result is not yet ready. So there is some advantage in having an HPV DNA system, particularly if you have a test that can produce a result within a few hours. And there are several of these platforms which are now being used as point of care, which to me is actually an advantage of the Hpv DNA system over every other type of system. VIA can also provide you with an almost immediate result, but then the issue of specificity it makes it really unpopular with pathologies, and then the need that we also overtreat women, because the chances are that you are likely to treat those who do not even have any major disease. They also need, there's a lot of variance across board, and you require a lot of training and workload to improve the performance of the test. It's also important to ensure that we have a good coverage of the population that we want to handle. The scientific evidence for HPV testing is now established. HPV testing is now regarded as a key tool for cervical cancer prevention, which requires a comprehensive set of interventions across a woman's life course and based on a thorough understanding of the natural history of the disease. And at a minimum, the WHO global strategy has actually recommended that we should screen the woman at least twice in a lifetime over a 10-year period, which to me is good. Even when you do it once, I think it is still beneficial. And regardless of the screening to use, an organized screening program must include high coverage of the women at risk. and a prompt follow-up and treatment for all women with abnormal results. I'm one of those who strongly believe that when you offer screening and you cannot treat, that is actually unethical. There are quite a number of options for screening strategies with HPV tests. We can combine HPV with cytology triage in HPV positive women. The advantages are that we can identify women at greater risk of precancerous lesions. However, the disadvantages are that you require more services for this type of service. HPV and VI triage in HPV positive women can also be done. And also, we can do HPV and treatment without triage. All these have advantages and disadvantages. But what I do advocate for is that we must do something. We must screen. And failure to screen indicates that we'll continue to see women with advanced cervical cancer, which to me is actually a major disaster and is indicative of a destructive and a fragile and a health system that cares for nobody. There are commercially available HPV testing for cervical cancer screening, and this varies in terms of what they are picking. And quite a number of them, Capture, the CareGen, CareHPV, Cobas HPV test by Roche, Savista, Optima HPV, and then the Gene Experts. So quite a number of these are available, and the important thing is that it just have one. Whatever works for you, please use it. And in choosing which HPV test to be deployed in the screening program, consideration must be given to results of clinical trials, clinical validation of the test, and other operational and logistic aspects of the test and its requirements. As far as HPV test for cervical cancer screening is concerned, it will either be for DNA or for RNA. For RNA, we are looking at amplification of the E6 and E7 protein, or using monoclonal antibody technique. And the type of tests are on the right. But for the purpose of this discussion, we are looking at direct genome detection or amplification, or application and genotyping of HPV 16 and 18, which is important. And quite a number of the tests are listed on the right. It is also important that in whatever test we want to deploy, that we need to consider the cost in terms of this treatment. And the two considerations are important: the cost per person and the total cost for the program. And planning and consideration must be given to the cost of the initial investment to set up the HPV test-based program, recurrent cost, and operational aspects of the program. And costs to consider will also include purchase of HPV tests, equipment and supplies, training, community education, and treatment. And it is also important to check the expiry date of the reagents. Many of the reagents have expiry dates. And then the issue of storage is also important, particularly in Africa, where the temperature can go high up. So it's important that we ensure that we do not buy reagents that are about to expire. And the WHO cervical cancer prevention and control costing tool can be used to estimate the cost of setting up your program. In terms of procedure, once a sample is taken for HPV testing, it generally requires transportation to the laboratory for tests, and the quality of test result will depend on the quality of the sample taken. Healthcare workers and clients therefore need proper training on how to take the HPV test sample, as well as the procedure for transporting the sample to the laboratory. And there might be need to maintain cold chain sometime. And as I've said, these tests have expiry dates, so please watch out for the dates. And tips on managing a woman with HPV test result. And it's important that women with HPV positive tests will require follow-up. The fact that they have HPV test does not imply that they actually have a pathology. But then we can either offer immediate treatment, especially when they have high-grade HPV, or try with another test, cytology, VI, or referral for colposcopy, which to me is actually more superior than offering immediate treatment. But whatever you adopt, it is important that you have a thorough understanding of the population that you are serving, the challenges of follow-up, and you also don't want to lose them. But all efforts must be made to ensure that women with HPV positive test results receive follow-up care. And loss of follow-up is a reflection of the barriers to access to treatment. It's important to bring to you this important study, which has just been published at the HPV Stat in Papua New Guinea, to show clearly that you can actually, that point of care Hpv DNA testing of self-collected specimen and same-day ablation treatment can offer actually qualities screening service to our women. And I've deliberately put it there for you to go through. It's a new publication online, July 22 this year. I've also, using my contacts, spoken to a few of my colleagues across Africa as to what exactly is happening in various countries. One, I have information as to what is happening in Mali, in Uganda, in Ghana, in Kenya, and Nigeria, as well as South Africa. I say clearly in Mali, they're using GeneXpert platform, and mostly in research settings. In Uganda, it is also in research setting, particularly in HIV treatment setting, and is available within the PEPFAR-funded programs. It is still not widely available within the population. In Ghana, using GeneXpert platforms, it is available in private facilities at a cost of $23. In Uganda, it is free because it is in the PEPFAR treatment program. In Mali, it's also free within the context of the PEPFAR treatment program. In Kenya, what we have is that it is available in private facilities. HPV DNA is available in Kenya. For healthcare worker collected sample, they charge $80. For self-sampling by the client, it is $50. It is still not widely available across the country. In Nigeria, let me talk about South Africa briefly. In South Africa, they still use cytology for screening, and cytology is free in South Africa. They are yet to adopt HPV DNA sampling. With respect to Nigeria, it is important to say clearly that within the HIV treatment program, cervical cancer screening is free, but they are using VIA and offering treatment. But then it's also important to highlight that Nigeria might actually become the first country in Africa to offer nationwide screening service because of a new development, which I will talk about pretty soon. This is actually a community project initiated by a first lady of Oyo State. That is Oyo State there on my screen. And what the woman did was to set up a screening program using COBAS machine. And since 2014 until 2020, they've screened a total of about 2,000 women, and you can see the number of positive. This is actually 24 for 16 and 18 14 combined for these. Another high-risk type 18. So this is actually, I wouldn't call it a pilot. It was a form of community service by an NGO led by the First Lady of Oyo State. Unfortunately, they've not been able to do any since 2021 because the reagents expired. You will realize I kept on talking about expiration of the reagent and so on and so forth. In this setting, those who come from outside to get it done, I think will be charged $15. So as I said, what are the lessons for that Oyo State HPV DNA pilot? It's a new test, and they discovered that doctors were not requesting for it. The yield was low because of that reason. The reagents expired, they were not ready to pay. And then the conservative physicians kept on asking for pap smear instead of HPV DNA. And so there's a lot of need for education if you want HPV DNA to be adopted. And then I said the 2021 WHO guideline for screening and treatment of cervical cancer recommended HPV DNA and is the preferred screening method instead of VIA and cytology for the young population. And HPV DNA requires less frequent screening. You can do it once in 10 years. And self-sampling, self-collection of samples are feasible and practicable, as in that publication, the HPV stat, which I showed. How then do we key into the 70% coverage of the WHO initiative? One is for us to switch to HPV DNA. It's the only test that will allow us to test a large number of samples. You can't do that with the cytology because there are limitations. But we need to understand barriers to access and create an enabling environment. We need to establish treatment services and integrate testing and treatment into a PhD setting. We need to promote screen and treat approach, ensure that you are going to get your supplies regularly. We need to strengthen laboratory capacity and ensure publicity. And above all, we need to educate both the client and the provider and our physician, and also publicize the services. Without doing that, we might not be able to go far. I did mention that Nigeria might become the first country in Africa to have a nationwide program. The Nigerian Health Insurance Authority Act, which was signed by the president this year, clearly promised to ensure health insurance coverage for all Nigerians, which to me is a unique development, and will actually escalate insurance coverage from 5% over several years now to almost all. And within the basic services available within the S is cancer screening. But then I must admit that what we have there is pap smear. But I promised this meeting that I'm going to move. I spoke with the Director General of the National Health Insurance Authority this morning, and he has requested for a memo that will help them implement HPV DNA. So what we now need will be the services. And I thank you for the opportunity to be part of this discussion. Thank you, everyone, and I appreciate you.
Thank you so much, Prof, and thank you for that very enlightening presentation. I think all participants would agree. You've mentioned that cervical cancer, we know, is the one cancer that gives us time. It's also takes about 20 years or more for cervical cells to change into cancerous cells, and therefore there is enough time to act. And recalling what Gandhi said, the future depends on what we do today. Today's conversation is going to be very critical in conversations around how we can amplify the use of HPV testing in Africa to continue with the journey for cervical cancer elimination. One thing I've picked out is we need to understand the population, we need to understand the environment, and also understand the people that we're trying to serve and the barriers or enablers that exist. And to bring us to that understanding, for this talk, we also have Karen Nakawala Chilowa, who is from Zambia. She's a cervical cancer survivor turned advocate. From Teal Sisters, she founded Teal Sisters in 2020 after her lived experience with cervical cancer. Karen is on the call today, and she's going to be speaking to us about her lived experience. She's our case presenter today. Karen was appointed to sit on the same task force as Prof. Adewele on the task force on cervical cancer elimination in the Commonwealth. She has also spoken in numerous high-level meetings, including the United Nations Assembly in 2021. She also chaired the launch of the WHO screening guidelines on cervical cancer in 2021 and spoke at the CHOGM 2022, the First Ladies Networking Luncheon on cervical cancer in Rwanda. Karen is a friend and a dear advocate. Karen, the mic is yours. Take it away. Thank you.
Hi, good afternoon, everyone. Am I audible now?
Yes, Karen, we can hear you. Go ahead. Okay. Thank you.
All right, thank you. Thank you so much, Abenda, for this opportunity. And of course, thank you so much to Prof. Adewele. It's always enlightening listening to him. I've been struggling with the network, as you can see. So I'm just trying to see if I can share my slide. It might take a bit of a bit of time. Guys.
As Karen is setting up, just a gentle reminder, John Black, I've seen you posted on the chat. Thank you. Others, please feel free to chat, to post on the chat your questions, your comments. We will be having a question and answer session after this, and we can respond to both Prof's and Karen's presentation. Thank you. Karen, back to you.
Thank you, Benda. It's taking its sweet time. I might have to ask.
I can share yours. Yeah.
I can share yours. Mr. will share. Thank you.
I think probably share. Okay, cool. All right, so thank you very much. As Benda has said, I am a cervical cancer survivor. I was diagnosed in 2019 and I was treated right here in Zambia. So I started Till Sisters Foundation after my treatment. And I think it's because of my experience throughout my treatment. I realized that not a lot of people were talking about cervical cancer. And so I thought we'll change things around and, you know, take the bull by the horns. And that is how Till Sisters was born. We're currently sitting with just over 140,000 women who are actively engaging in cervical cancer and other cancers as well. So it gives me great honor to be with you here today, and I hope you pick something from my presentation. We can go to the next slide, Mishka. So Zambia has one of the world's highest burden of cervical cancer. I think it is number 3 after Eswatini and Malawi. And its high incidence is linked to the heavy burden of HIV with female adult prevalence, which is sitting at 13.8% as at 2018. And age standardized cervical cancer incidence rate is at 65.5 per 100,000 women, and mortality is at 43.4 per 100,000 women as per Global Cancer Studies of 2020. And I think to me that is just too high a number for a cancer that we can actually eliminate and prevent. In 2020, an estimated 1,839 women died of cervical cancer of the 3,161 newly diagnosed. Now, these are those that presented to the health centers for diagnosis. So imagine if we collect the numbers of everyone that is sitting at home and have shunned away from treatment. Next slide, please. So we all know cervical cancer is prevented, easily detectable and curable in its early stages. But of course, I think we have lack of awareness and limited programs, which result in majority of women presenting to health centers when the cancer has already spread and it is advanced, which makes it very difficult and expensive to treat. So they come when it's at a point where the cancer just has to be managed and cannot be treated. Next slide. So how do we prevent and eliminate? We need to strengthen the WHO's 90-70-90 targets in order for us to not only prevent, but also eliminate cervical cancer.
It does appear like Karen has frozen. She may be having challenges with the network. Karen, are you still there?
Cancer as a.
Thank you.
Sorry, did I freeze there? Can we go to the next slide, please? Okay, let me try to connect from, I think let me connect from.
Maybe Karen, without your video, it may be easier.
Hi, apologies for that. Can you hear me?
Yes, we hear you.
Okay, great. I'm so sorry. The network is just playing up. So the one tool that we have right now is to eliminate cervical cancer is the HPV testing and screening. The HPV test checks for infection with high-risk HPV types, as Professor has already alluded to. The Pap test, which is also called a Pap smear or cervical cytology, collects cervical cells and looks at them for changes caused by HPV that, if left untreated, may turn into invasive cancer. Next slide, please. So how can we have a successful HPV screening and testing? We need to create demand. We need to raise awareness about HPV screening and its importance, explaining what it is and its benefits to the target audience. For instance, why should women have HPV testing and screening? Who should access the service, status, age, etc.? How is it done? We need these messages, curated and targeted at our audience so that they understand what the HPV screening is all about. There are quite a few myths and misconceptions about HPV, with one of them being women think that if the test comes out positive, then they are automatically going to have cervical cancer. And some of them think that the HPV test should only be done by women who are HIV positive. So all these are myths that we need to debunk in order for us to have a successful HPV testing and screening. We also need to create appropriate telemed messages for the target audiences. We need to translate messages into local languages, depending on the area, so as to cater for the rural community. I think the one cadre of women that we don't really look at, when it comes to curating messages are the differently abled women. I don't think we've really sat down and tried to find out if the messages that we are sending out there are actually working for them or if they understand. We have the blind people, so we need to have messages in Braille. We have our hard of hearing sisters. We need to have sign language messages for them. So even as we curate these different types of messages, let us cater for at least all the cadres, all the communities of women in order for us to be able to reach a bigger audience. And as we curate these messages, it's important that we include the extended family, we include the wider community, we include the husbands, we include the children. That way, they'll be able to understand. For instance, if a woman is positive and needs to go for treatment, they should be able to understand why she's being given that treatment and what will happen as she is having treatment, because some people have different side effects. So once they understand that, they are better able to manage and help the patient. And also peer-to-peer engagement is very, very important. I think we can learn from what has happened in the HIV space and use peer-to-peer engagement. Survivors like myself, I always say that survivors are the best advocates. Survivors are a bridge, between the patient and the doctors, because there's some things that some women are not really open about. And I think they'll be able to speak openly to another survivor, and they'll be able to be helped. They'll be able to face their doctors and address the questions that they may have once they speak with somebody who's walked the road, because it's also very easy for someone to relate to somebody who has walked the journey. So usage of survivors is very important, and that is why I'm so grateful, for having been given a voice and a seat at the table. And also the HPV screening, where possible, should be a part of routine screening. When I walk into a hospital, I don't have to start thinking, okay, so I have done my BP check, they've taken my temperature. What next? If it's possible, can everything just be done there and then? It takes a lot of courage for somebody to actually up and say, I'm going to do a cervical cancer screening, I'm going to do HPV screening. As we know that anything below the belt attracts a lot of stigma. So if somebody walks into a clinic, a woman walks into a clinic, I think it's better we make some of these things part of the routine screening. If they come and you ask them, have they been screened for cervical cancer? No, that service can be provided. Would they like to have the HPV, test done? That can also be provided. So I think it would be important to, if possible, to have screening as part of the routine. Next slide, please. So how do we address the barriers? Now, the HPV test should be given for free or made affordable, especially for women who are HIV positive, because they are at a higher risk of infection, and those from low middle income countries. For instance, women in the rural areas here in Zambia, they live under $1 a day. So if I am that woman, I would rather use that dollar to feed my family than to go and get screened or to go and get treatment. I have to go kilometers and kilometers to a health center to go and get treatment. So I'd rather stay at home and feed my family. So if we can have these tests done for free, I think that would be a plus. Also, the healthcare providers need to take time to explain to the client what the test is all about and why it is being done. I know a lot of women who would think that the HPV test is the same as going for the cervical cancer screening, VIA, having your speculum inserted and things like that. And so most people shun away from that because they do not have the right information. But if the healthcare providers can take time to sit and explain how the procedure is done to the client, then I think we'll have a lot more women receptive to the screening. The healthcare providers in the clinics or health centers doing the screening should be adequately trained to exhibit compassion, patience, kindness, and understanding. Like I said, it takes a lot of guts for somebody to walk into a clinic, to have a cervical cancer screening, to have HPV screening. I'm sure there would have been a lot of soul searching. I give myself as a perfect example. It took me years to actually go and get screened. I was literally forced to go and get screened because I'd heard horror stories about how people are treated and how painful it is, how there's just no compassion, people just doing their job. They do their job mechanically and that's it. So it would be nice if we can get staff that are compassionate and understand that it has taken a lot of willpower for a woman to walk into the clinic to get screened for cervical cancer or get HPV testing. Next slide, please. Screening facilities should be able to cater for women living with disabilities because ordinarily they find it hard, to get screened physically and even mentally. There's a lot of stigma, attached to women with a disability. So I think we need to look into how we can make it friendly for every person to walk in there freely, whether they're doing the cervical cancer screening or HPV screening. Let's just make it as comfortable as we can, especially for those that are differently abled. Self-collection of samples should be allowed and encouraged so that more women can access the services because it will be done in the comfort and confines of their home. Given a choice, I think I will go for the self-sampling because I'm going to be in my home. I'll be relaxed. Nobody to rush me. I'll take my time and take the sample. Unlike going into the clinic where you've got all the prying eyes and everybody looking at you and pointing fingers. So I think a lot of women, once this is available to them, self-sampling is available to them, I'm sure we're going to see an increase in the uptake of the HPV screening. Next slide, please. The test and the treatment, where possible, should be well aligned and done in one visit. Screen and treat. Because that way, I know there are a lot of women that will go do a test, not just HPV test, some other tests as well. And then when they're told to come back, after maybe 2 weeks, 3 weeks, 1 month, very few will actually go back to get those results. So if possible, it would be nice to just screen and treat that way. We're not losing so many women, when it comes to follow-ups. If results are not ready and you give the client a date for them to come back, make sure the results are there and are accurate. In case they are not ready, the client must be informed timely. It's actually very disheartening for somebody to travel all the way from wherever it is that they are to go to the clinic, and they get there and they're told that the tests are not ready. Why didn't I receive a call? Why didn't somebody bother to call me and tell me, do not come on this date because the results are not ready? Why don't you come on another time? So I think patient navigation is key. Another way we can actually gain success is if we go to places where we have large number of women, in one place, like for instance, the universities, the colleges, the churches, the prisons. It's very easy because they're in one location. So you go and collect the samples, you take them for testing, you go back and give them the results. They don't have to follow you because they're in one environment. It's much easier to work with them than having walk-in clients. Of course, we can't run away from that, but I think those are just some cadre of women, some pockets of women that can be targeted and I think have success with the screening. Next slide. The other challenges are inhibitive costs that the providers incur. I think Professor had spoken a bit about the high cost of some of the reagents. So these may result in shortages of test kits, which may force us to go back to the VIA. But fortunately for us in Zambia, it is much better because the reagents are bought back to back. And so the backlog is cleared. Clients not receiving their results on time because of not having test kits on time because of high cost. This is another barrier. Another challenge is clients not giving accurate contact details, making it difficult to reach them in case they do not show up. Most of them, like I said, will not go for follow-ups. And when they try to call them, they find that the numbers that they give are not going through, or maybe they've changed the numbers. So I don't know how it can be done, to make sure women give the correct details so that it's easy for the health centers to make follow-ups. So that is also a challenge. And the other challenge is that most of these programs are donor funded. And so it will depend on the availability of the funds and the conditions that are attached to the funding. I think we all know that donors come with their own conditions when they're giving you money. So sometimes those can be very restrictive as well. That is a challenge. Next slide, please. And so in conclusion, HPV testing can be a tool to fast track the elimination of cervical cancer in Africa if we put the following measures in place. Create demand by raising awareness about HPV screening. Professor spoke about education, education, and education. Inform the public about HPV testing and its benefits through various media. Have decentralized testing across the countries and have the test readily available on demand. Provide the test for free or charge the bare minimum. Encourage self-sampling. Screen and treat, very important. Expedite delivery of results. I think when we started here, I was getting some women calling me up and telling me they were only getting their results after 2 months, after 3 months, but I know things now have improved. So it's very important that we expedite delivery of results. Lobby for reduction in prices from pharmaceuticals so that countries are able to buy in bulk or back to back in order to have a continuous flow of supply. Because I think it's very disheartening. You go, you do your test and you can't get your results because there are no reagents, there are no testing kits. So it's very important to have a continuous flow and also demand. People should be able to get the tests on demand. So we need to lobby for reduction in prices as well. Next slide. Thank you very much, and apologies once again for the intermittent connectivity from my end, but I hope you've picked a thing or two from the presentation. I thank you.
Thank you. Thank you so much, Karen. And thank you everyone who has stayed on the call. We're now at that very exciting time in the conversation where we get to engage, interact, and ask the burning questions that we do have that may have been sparked by the conversations that have already been presented by Professor or by Karen. And I see on the chat, we already have a question from Nyawera. Nyawera has asked, how might we harness the existing molecular framework in the continent developed for other infectious diseases to increase access to HPV testing? I'm going to pass that question to Prof. Kindly, Prof, would you respond to that?
Thank you so much, Brenda. The answer, straightforward, is yes. It's one of the advantages, and it's in my presentation, that we can actually use those platforms, and it's a question of buying the cartridges, or cassettes, and we will use it for HPV. So to me, it's the easiest option for our countries. Once you have gene experts and you are using it for TB, HIV, please go ahead, you can use it.
Okay, thank you so much, Prof. Excuse me. Recognizing that Karen had requested to leave a bit early from the call, we do have another 20 or so minutes for question and answer session. Is there any burning question that you may have for Karen? Feel free to raise your hand and we'll be able to see you and ask. As we do so, Jane Matambo has asked, is there a preference for the use of HPV tests on women that are HIV positive as opposed to that are HIV negative? Prof, I will pose that question to you as well.
The answer is yes and no. It wasn't deliberate. It's just because the HIV programs are funded. And it took quite a lot of challenge before we started using the same structure for cervical cancer screening. In fact, initially, the USG said no. But I manage an HIV program, one of the largest in the country, and I said, please go ahead and use it. The same nurse that is being paid for by PEPFAR to offer HIV testing and treatment can also do cervical cancer screening at no extra cost. The same couch that we're using for the HIV patient can be used for the HIV negative. So it's just a question of using the same facility without incurring additional cost. So that's why it came up, and it's also now part of the Red Ribbon, Blue Ribbon initiative, which was flagged off under the Bush administration. So it wasn't deliberate, it wasn't designed, but because there was funding for HIV, and we also saw that there is a connection between HIV and HPV. Interestingly, both viruses are Nobel Prize, HIV and HPV. And we know that the HIV person is actually at a 6 times risk of developing cervical cancer than the HIV negative.
Thank you. Thank you, Prof. I hope the 2 questions have been answered, Nyawera and Jane. I have a burning question for Karen, and this is to spark conversation around the lived experience and what it is that you're doing in the space in Zambia to garner more support in the country for women to take on. You mentioned earlier that we do need targeted and curated messages. And in your introduction, you mentioned you have about 40,000 women on social media who are constantly engaging on the conversation on cervical cancer. Could you share a bit of your experience in how it has been running the Teal Sisters, getting women to have these conversations, which we like to call below the belt, and which are often not talked about because it's taboo to talk about sexual reproductive organs and the various things that go as taboo in our region. Karen, how have you overcome this barrier to be able to give curated messages in the region? Thank you.
Thank you, Brenda. I think that is actually ongoing. Trying to get women to start talking about their sexuality. I think first it was very important to make them understand and know that they are in charge of their bodies, and so they need to know when the body is talking to them. And I think when we get over that point, it makes it very easy for us to start talking about anything. And that is how come it has been very easy for us to start discussing cervical cancer issues. Even if you are on the chat, you actually notice that every time you post a direct question that is below the belt, within a few minutes, you've got so many comments. And everybody just wants to know. Some people will slide into my inbox because they're shy. They don't want to be seen, as asking certain questions because maybe there's an in-law on the platform. But I've come to learn that sugarcoating anything is not working. If we're going to call the vagina, it is a vagina. That is the name. We can't give it another name. So we have to be blunt. If I'm going to talk about the cervix, I'll talk about the cervix. Where is the cervix? Okay, and that is the only way that we're going to get people to start talking, such that even when you curate messages, they will understand because they know what you're talking about and you're not beating about the bush. And I think we need to understand that cervical cancer intersects very much the African culture. And we need to get to a point where we start to discuss these things without feeling shy about them, because that is the only way we're going to save our lives. And this goes for both men and women. If you notice, men don't want to talk about the prostate cancer, just like they'll cringe when you start talking about cervical cancer. So I think it's just important that we call a spade a spade. If we're going to talk about cervical cancer, let us talk about cervical cancer in its entirety. Let us not beat about the bush. I know in Africa, anything below the belt, there's stigma, you don't want to talk about it. And that is why a lot of women are dying in silence. They don't want to go, to a clinic and tell somebody, I have been bleeding nonstop. Instead, they'll sit and believe that the person who will tell them, it's your husband's girlfriend who has bewitched you. So unless we get to a point where we can freely discuss these things. And what I'm fighting for now is we need to start discussing sexuality with our children in our homes before the world teaches them what it is. So we need to be discussing as parents and talking to everybody and not beat about the bush.
Thank you, Karen. From what I'm hearing from you is that cervical cancer needs to be a breakfast table, lunch table conversation, as opposed to what it is right now in hidden corners where everybody wants to hide behind the direct messages or hide behind intimate conversations with their friends, but they don't want to come up with what is really ailing them. Karen, you're running a charity organization, and we do know that grassroots organizations are not always very well funded. How have you overcome that to still be able to do advocacy in your region? And I'm asking you questions. We still do have questions for Prof, but I'm asking you because I recognize you had indicated you may be leaving earlier. Thank you, Karen.
Benda, unfortunately, up until now, we still do not have any funding, but I think that has not stopped us from doing what it is we've set out to do. So we embark on different fundraising ventures, and we still are able to carry on and carry out the programs as we wait for funding.
Wow. So what you're saying is don't wait for funding, do what you can with what you've got where you are at, even as we're waiting for an enabling environment for you to do advocacy. Thank you, Karen. Isaac, Prof, I'm coming back to you. In one of your slides, you may not have noticed it, but it was a shocker that we have some countries giving free of charge HPV testing. And in my own country, where I'm sitting very pretty right now, it costs us $80 for healthcare assisted and $50 for self-sampling. You have been a minister of health in Nigeria. What could governments do to ensure that they're creating an enabling environment for us to reach the 90-70-90 elimination strategy?
Well, thank you, Benda. That's actually a tough question. I've always advocated that we needed to go beyond political will in Africa. We need to really acquire political commitment and action, because will alone is insufficient You change the dynamic. So we need political commitment and action at the topmost level. And I'm quite excited by some of the discussion by Karen, what she's been able to do. I've been to Zambia a couple of times, so I know what is happening there. Zambia is one of the good examples in Africa that we can copy. So I think there is also need for us to understand that prevention is cheaper than treatment. By the time they develop advanced cervical cancer, there's nothing that we can do. And when you look at the cost that will be incurred, some of them will be transfused, some of them will be given painkillers, antibiotics, and occasionally given radiotherapy, just palliative. The cost of that is huge. So I think what we need to talk about is education. And education, I didn't add policymakers. We also need to educate policymakers. It's important. I think what has made things easier for me when I was in office was that some of our top policy persons, the mother of the wife died from one of the cancers. So I think that created a sense of urgency and appreciation of what it is all about. And knowing full well that it is preventable, largely, I think is enough to stimulate them into action. So I think there is need for us to table this, even at the level of the African Union. Let it be said that this is a cancer that is worth investing in. And I'm sure that things will change.
Thank you, Prof. I'm going to open the floor for others who may want to ask questions. The floor is open. Anyone with a burning question to either of the presenters?
Sorry, Brenda, may I beg to leave now?
Karen, thank you so very much for your time with us. And we really appreciate recognizing the circumstances. I'm really, really humble. Thank you. Do take care now.
So
thanks.
Thank you. Bye-bye.
Thank you. Any burning questions for Prof? Or even sharing experiences of what has been going on in your programming? I see we have Bisrat Fanteye Danbaru. I hope I've pronounced your name correctly. You may unmute and speak, Bisrat.
Yes, thank you, Brenda. Thank you, everyone. Thank you for the nice presentation offered by the two eminent speakers. I was so happy attending the presentation and the discussion. And the question even you, Brenda, raising for Prof. I would like to ask just few questions for Professor. One, how do you explain the turnaround time for HPV? In our country, the HPV screening is like supported by partners like PEPFAR, okay? It's solely dedicated for those positive women for screening as a primary screening algorithm. And then those positive, the other challenge, one is the turnaround time. It stays like on average 21 days, so that the provider should have to follow the woman who turn out to be positive to come again for VI algorithm. Or, I mean, the recommendation after HPV is, I mean, VI, if the woman turns positive. So always, the providers always, whatever we did, whether with HIV, with HPV, or again, if she's positive, why do go into multiple times? Why don't we do VI directly? So would be in short words and terms and scientific grounds to explain for them to go that way even. The other third point is the point of cost that how can, I mean, partners, how can we lobby, how can government be committed to avail? We are now in short of funds and in short of the reagent, so the HPV testing even have stopped currently, but we are expecting that we'll get the fund and we'll continue. So these 3 points, could you address for me? Thank you very much.
Can I ask this side a question? What type of strategy are you using for screening? Because other than cytology, none of them should have a turnaround time of 21 days. You must be using cytology.
Yeah, the cytology are done I mean, like in higher tertiary level structures and facilities, and you know, it's very few percentage. We are opting and we are moving to the WHO target of 90-70-90. In order to reach that, the HPV has ease and access, as the Karen had told, that, you know, massive screening will help us in preventing and reaching the control mechanism.
That is the advantage we have with HPV DNA. You can actually do many tests per day, and the turnaround time is short. Some of them, a few hours, depending on the type of platform you are using. So the COBAS, which is used in the Oyo pilot, could test 100 samples a day, and you get the results same day. So the patient can wait, have a bottle of Coke and some magazines to read or watch a movie, and while that is on, the result is ready. So none of us, no African country can deploy cytology effectively. South Africa has done it, but even then there are hiccups. That's the only country that has deployed it across. So let us do away with cytology because it is logistically demanding.
Thank you, Bisrat, and thank you, Prof.
Thank you.
I think we have Jen Matambo with a question. Jen?
Good afternoon, and good afternoon, everyone. Good afternoon, Prof. Beautiful presentations there from Prof and Karen. So I just wanted, it's a follow-up question from the one that has just been previously answered by Prof. So for us in Zambia, I think that the turnaround time, we have a very long turnaround time in some instances, simply because of the centralized testing that we're doing. So we're testing now in a lot of facilities across the country. So for VIA, we are at 276. Almost all the districts have been covered now. So HPV is also trailing behind VIA side. So, but now the turnaround time is really long, and then we tend to lose these clients. When we have an HPV positive client, we tend to lose them. We have to put in a lot more effort to just bring back these clients. Karen talked about clients giving us the wrong addresses, the wrong phone numbers, the numbers that are not going through, and some addresses that they give us. So, you know, just on a light note, in Zambia, sometimes we have places where when a family shift or relocate, they relocate with their door, which had a plot number. So then that's how we tend to sometimes lose these clients. So for us, I think the turnaround time is affected because of the centralized kind of testing. We're using the Hologic Panther machine now, which is, for example, in Lusaka, it's only at UTH, at the University Teaching Hospital. I think, Prof, you must have visited UTH at some point. So, and then we have facilities that are further away districts, others are even over 300, 400 kilometers away. And so by the time they're receiving the results, you know, I think that's what has contributed to the turnaround time. We're trying to look at point of care or near point of care tests like the Gene Expert, but also on the Gene Expert, we have disease prioritization where we have priority TB, viral loads, and I think there was COVID at some point, which was even more prioritized than TB. Then we have TB, we have viral load, we have EID, and then that's when we have HPV. So I think those are some of the struggles that we have when it comes to turnaround time for our results. We have results that we've not maybe the clients have not received them even as far back as probably last year, September, October. So what we have done is, in some places, especially the further away places, we have kind of rearranged the algorithm where when a woman comes, you're collecting HPV, and then you go ahead and do a VIA. I know it's away from the protocol, but then for places where women have to walk kilometers and kilometers just to access cervical cancer screening or to access their HIV medication, where we have set up HPV screening as well. So that is what we have done, just to ease the burden of having these women come back to the facility, walk all those kilometers just for them to come and do a triage test after an HPV positive result. So I know that we've deviated from the actual protocol, but I think we're looking at what is working for that woman who is right deep in the rural areas. So yeah, so those are some of the big challenges that we are facing with the turnaround time and also with the triage test for HPV positive women. Thank you.
Thank you, Jen. Prof?
Thank you, Jen. I think you've identified practically all the challenges in Zambia. One, I think we should let go. Quite often, the gynecologists want to see to every case. I think there should be decentralization. Not only decentralization, we need to do task shifting. Share some of these activities with other people. And as far as I'm concerned, the challenge is that you have an excellent facility at the University Teaching Hospital, your center of excellence. But then that center of excellence is insufficient to handle the entire country. And so I would rather advise, let's decentralize into districts and also deploy point of care tests. And those cases that are really troublesome, large lesions, especially when you triage, large lesions, and those who are frankly malignant, send them to the teaching hospital. But a situation where you want to send everybody to Lusaka will not work, and you will lose many of these patients.
Thank you. Thank you so much for that dialogue, Jen and Prof. Are there any other questions? Jen, do you have a follow-on question? I see your hand is still up.
I'm
any
sorry,
other
it's an odd hand.
questions? Any other comments from the participants? I see we have John Black Kabuche had mentioned that in Uganda, there is also a Prescript Tech project, an EU Horizon 2020 project with participating organizations from Netherlands, India, Slovakia, Bangladesh, and Uganda. And he's given a link there. The project also incorporates AI and mHealth and community mobilization, etc. And he's also mentioned about the Rwanda Electa Foundation program to set up HPV screening services. Do we have any other additions or any other projects that you would like to speak into? And we're almost coming to the back end of this conversation. So any burning questions, please?
Hi, Brenda. Sorry again. I just wanted to hear how the response is for clients paying for the HPV test for the countries that are charging for the test, because we have been struggling with purchasing of these test kits because of the cost, but then there's no cost to at point of delivery. So I'm just wondering if it's an idea that we can buy in. Yeah, so how has been the response from countries that are charging for that?
So probably
various countries have different strategies. I think it is only in South Africa where the liquid-based cytology is free. In many of our countries, people have to pay, and that's why we've had challenges deploying it across the country, except where it is funded. So it is important that we need to fund this program. It is only when we fund it that we can be made available. Access is important. Once you put costs, you are going to keep people away. So for it to be universally available, we must make it free or at little or no cost, very cheap.
So Probably, thank you, Prof. Maybe if I can add to that, Jane, I have been in the cervical cancer space for now over 10 years. And we started from where it was touted that VI was the best option for Africa and other LMIC. And in the work that I was doing then, we used to go to the villages and set up laboratories to do cytology on the ground, take the technical experts on the ground to be able to do the testing, as well as the results reporting on the ground, and the women would leave same day with the results for their cytology. Fast forward to HPV testing, and one of the things that I've realized, and we are working on in Kilele Health, is the realization that there is strength in numbers. For example, the reason why a test would be $80 in the private facility or in the lab is because they are going to have to do that one test as opposed to doing the 90 cartridge at one go. So they have to cover their costs of all the other tests that may be wasted if they have to run the test efficiently for the patients or the customers to be able to be served in a timely manner. And so some of the things that we're doing now is advocating for quantity discounts, where then we're looking at aggregated costing. In my project, in my program, we have a campaign that we're calling Tamani Yetu, where we're looking at the number is 4 million women and girls in 5 years. And now the conversation is, it doesn't matter where they're coming from, be it from Nigeria or Kenya or South Africa. If we're able to get aggregated numbers from these countries, the manufacturers, the suppliers should be able to negotiate with us to be able to get that number down so that we get the numbers and we get our women secured for the future and our girls also for the HPV vaccination for the future. That is one. Secondly, utilizing the lived experiences. You've just listened to Karen speak very passionately about the things that she's doing. And one of the things that caught my attention was when she said she would rather from the comfort of her home be able to self-sample and send that sample to the facility for it to bring back the results for her. In a time where we have AI, we have mHealth, we have all these capacities and capabilities, and places where we have even very high mobile penetration. So people have the gadgets that can be utilized for their results dissemination. The only people we need to be worrying about are the ones who report positive for HPV, because we know those are the ones that we really need to reach so that we don't lose them to follow-up. But for the others that are getting a text telling them your results are negative, come back in 5 years, we ought to start looking at, from an advocacy perspective, how do we communicate the benefit to the woman so that they show up in large numbers? How do we communicate to the governments that it's cheaper and more cost efficient and more enabling for a healthy nation to build their wealth, that they invest in this infrastructure and capacities? And from a policy perspective, report back to the barriers and challenges that we're facing, so that the governments, as they're making decisions, they are also alive to the challenges on the ground, costing being one of them, awareness and education being the other, and at the same time, technological adoption being the other, because we can set up all the systems we want to, but ultimately, if they're not being utilized by the people who ought to benefit from them, it is wasted capacity. I'm very passionate about this subject, so I will stop there and hand over the mic. Hopefully I've answered you, but all of us pushing in the right direction together is what is going to change this game and make it possible for our women to prevent now for the future. If there are no burning questions or rejoinders to the conversations on the table, I would like to hand over back to Charles and Mishka so that we can go to the next level for this conversation. Thank you. Mishka, back to you.
Thank you, Benda, and thank you to our wonderful speakers today and to setting a great pace and tone for our whole series for this year. I'm going to turn over to Charles to give us the highlights and close us out, but thank you again, everyone.
Thank you so much, Mishka, and thank you, Benda, for moderating our session for today. And thanks to our speakers, Professor Adewele and Karen, for the informative presentations. We are so grateful that you are able to join us and share that information with us. So thank you everyone for joining us for this first session of our 2022-2023 Africa Cancer Echo year. And we are going to share the recording of the session on Basecamp. And we're also going to share the speaker presentations. So look out for that in the coming week. So our next session will be held on October 20th, same time. And as we had earlier communicated, the curriculum this year is going to follow the core elements of the National Cancer Control Plan. So today we just looked at a topic on prevention, and the next one will be on cancer diagnosis. And specifically, we are going to be looking at use of telepathology to advance and streamline quality cancer diagnosis as part of the cancer continuum pathway. So we hope that you will join us as we continue learning, and look out for the agenda, the detailed agenda in the coming week. And we hope that you'll be able to join us. Otherwise, thank you very much for joining us, and have a good time. Thank you.
Thank
Over
you.
to you,
Thank
Beda,
you.
maybe.
Thank you. For everyone who has joined us today, we're really grateful, and we look forward to continued engagement. Diarize, the Echo is the place to be every third Thursday of the month, and talk about it on social media as well. Let your friends know that there is a platform where we can share knowledge and be able to learn together. I hope today's has been valuable to you as it has been to me. Thank you. Enjoy your evening.
Thank you, Brenda. Same to you.
Thank you.
Bye.
Thank you, everybody. Bye.
Bye-bye.